I was really taken with the mission of the Schwartz Center. Its programs are all about strengthening the relationship between patients and their professional caregivers. It's all about preserving the human connection in healthcare, and I think in a time like today with all things healthcare reform, but also the severe pressure on cost containment, it's so important to remember what's at the core and root of healthcare.
As we all know, healthcare has been changing, and it's been changing dramatically, partially as a result of the Affordable Care Act, but also changes that are being driven by the imperatives to better control cost. And as the Commonwealth Fund points out in its new report, healthcare spending is well on its way to consuming more than 20% of our gross domestic product, yet we've not necessarily seen the benefits that other countries have seen from their healthcare systems. So how do we address the cost issue while improving quality and better engaging patients? That's the topic of our program today, and we're honored to have 4 outstanding speakers, all of whom have deep knowledge on these issues.
What is fundamental delivery system reform about? It's very simple. It's about making it easier to do the right thing. It's about making it easier for our nation's health professionals to come to work every day and make wise decisions that are in their patients' best interests. Too many times, they can't do that now because the systems in which they work make it counterproductive or difficult. We can't ask nurses, doctors, respiratory therapists, social workers to be heroes every day, to do things that are not in their interest or in their institution's interest. We have to find ways to liberate them to do what they know their patients want and what they want. So there are several critical pieces of this. The first is to collectively conclude that we're paying enough for health care. There is always, I think, on the part of providers of care, and maybe on the part of patients, the sense that there really isn't a limit. There really isn't a limit. That, sure, we talk about a limit, but there really isn't a limit. There's always going to be more. There's never going to be a point where anyone says there is an envelope beyond which we can't go. 18% of our GDP, 20% by 2021 or 2022. 1 in every $5 produced by our economy going to one sector. That should be enough. Last night may have been the first time you ever heard a president refer to paying for value in health care. It just shows you how far this idea has seeped into the consciousness of our political leaders. It is not easy to get something in the State of the Union address. I can tell you that. For that to get into the address means that this is top of mind of our nation's highest elected officials. The other point I wanted to emphasize, and particularly useful for this audience, is engaging consumers more in their own care. There is a increasing understanding that there is a role for consumers of care in exercising choice. Now, some people believe that the most important choices consumers make is in the plans they choose. Our thought is that the most important choices they make is at a more granular level, which is where they choose to get their care and how they choose to manage their own illnesses, and that we can make those choices more relevant and more understandable to patients so that they can make good choices and be encouraged to do so.
So doctors are doing a lot of things in the United States that we don't need to be doing. There could be many other people providing some of those services, and that's going to be critical, not just from a manpower standpoint, but also from the cost of care. And some parts of the country have adopted that in very different ways. I think we're slow to do that here in New York. We haven't had to, because we've got a lot of doctors, and patients have come to expect that. But there are many areas where nurse practitioners, frankly, provide superior care. When you look at some of the data, they can perhaps spend more time They've got a different relationship. Now, not every single person in every single role, but pharmacists, it was big news here in New York when we went to pharmacists being able to deliver flu shots. Now, frankly, anybody in this room could deliver a flu shot if we gave you just a little bit of training. That was wise, but it made news here in New York. It shouldn't be like that. It ought to be that we're thinking about who can deliver what kind of care. But we've also got to educate patients. So we've got to get people comfortable with that. The other area that I would connect perhaps on in terms of this notion of the interaction between caregivers and patients is in the area of technology, and David alluded to that. So I find that when I'm talking to physicians, I'll say of our generation, right? We grew up without a lot of the technology. We didn't have electronic healthcare records, or if we did, they were in nascent stages when we were training. So we learned to practice, we learned to interact with our patients in a very different way. So then when you add technology to that, you make some changes perhaps around the margins. And a lot of times when we're talking about technology, I'll hear physicians say, it's slowing me down, or it's interfering with my relationship with the patient. Patients don't like it. And of course, if I'm sitting there and one of the physicians is doing nothing but looking down and typing notes, that's not conducive to a great relationship. The trick is, again, David alluded to it, those 25-year-olds who are out there in Silicon Valley or who are practicing in our hospitals now, who are thinking, they're leapfrogging. And when I think about technology, I think about it in a certain way and how I might use it with patients, or how the doctors at New York Presbyterian or elsewhere might interact with the nurses, the social workers, everyone. I think about it in a certain way. But when a new resident thinks about technology, when I talk to one of my adult children, they are light years ahead. Now, some things are completely off base and may not work, but it's connecting that interface where technology is not a barrier, it's not slowing things down. Instead, it's connecting in a different way.
As someone who sees patients on a daily basis, I'm not an administrator. I avoid administrative tasks at all costs, and whenever they ask for someone to be in a committee, I try to go to the bathroom. I'm always intrigued by the terms value and quality, because they come up a lot in the data. And it's there in all the people who are organizing and engineering our healthcare. And you know, from someone who sees patients, it's really different. Our hospital did a laudable project on trying to improve the care of patients with diabetes, one of the biggest drivers of healthcare morbidity and cost these days, in which every doctor got a report card on what percentage of our patients had their glucose, their A1C under 7, a measure of average glucose, and a few other measurements, lipids and blood pressure. And my numbers were abysmal. And it was so dispiriting because I feel like I'm a pretty good doctor. I work very hard. So I worked harder. I made more calls. I stayed through lunch. I stayed late. I missed picking up my children to work harder. And my report card didn't get any better. And when I wrote about this for the New England Journal of Medicine and the New York Times, I was besieged by letters, excoriatingly ones, and a lot of online things to the effect of, Dr. Ofri, are you afraid to look at the numbers? And the answer is yes, I am. But personally, I received many emails from individual nurses and doctors who feel rather besieged by these numbers because they don't necessarily reflect what is quality of care. It reflects a number that's easy to measure, and that's what people who measure do. And I wonder how many of them have actually sat in a patient room and seen what medical care is. You know, on Monday I have a long 2 patient care sessions, and I probably saw 8 patients with diabetes, and they would all be the same in data analysis, but they're not the same at all. You know, when we're compared, especially with medical errors, why can't we be more like the nuclear industry or the airline industry? Well, medicine is a human endeavor. It's 2 people in a room, a nurse and a patient, a doctor and a patient. It's not widgets, it's not a factory. I mean, I often want to ask these data-driven people, when you want a doctor for yourself or for your child or for your mother, how do you get that doctor? Do you go online and check their stats and pick them that way? I doubt it. You probably ask someone, who's a doctor whose judgment you trust, who will listen to you? Now, obviously, that's only part of it. We want to make sure that our doctors are board certified and have their medical knowledge, but that's only one part of the game, and how we view quality is a much more amorphous and much more sophisticated thing than the mere measurement of numbers, because we are taking care of people.
I definitely want to thank Julie and all the Schwartz people, because I think 4 years ago we became one of the first sites in New York, and it's been a very valuable resource to us, and we only see it growing. 18% is too much, but if you dig deep and you look at these European countries that have great health outcomes, they're spending 18% if you count the ability to retire with dignity, the ability to have decent housing, the ability to have social services that are comprehensive and in the home, an ability to grow old or be young and have the things you need, the social services. And I think what became aberrant in America, it sounds odd coming from a hospital CEO, is that we kind of gobbled that up, and we all are trying to fill in for that. And there's no way you can fill in for those social services that are missing in challenged populations in a place like Bellevue or a place like the Bronx or a place like West Harlem. So we're not targeting the money well. We save that money. I would like to dedicate it and use it for social services so we can raise the standard of living in this country. Corn subsidies in Iowa bother the heck out of me, because we're growing too much corn, which people turn into liquid poison and put into the bodegas of the Bronx and Manhattan and Brooklyn. And we have an obesity crisis in this country that is so out of control that everything we could do to re-engineer and change and make the best healthcare system will be undermined by that phenomenon. So that honestly, maybe it doesn't keep me up, it makes me mad. I can't help but comment on 300 million, not just hunting guns, but automatic weapons and magazines and accoutrements that exist in this country. I mean, there's basically a weapon per person, and some of those persons are infants. So to me, that's something that we have to grapple with. And I would say immigration reform, which was featured last night, is wonderful, but the President has made it clear that people on a 10 or 12-year pathway to citizenship will not get health care in the exchange and not get it in the Medicaid system. So, but they will get health care at all our institutions. So that it makes no sense to me that we have this many immigrants living in this country who are hardworking. My family were immigrants. I'm a first-generation college graduate in my family. This is America, and that makes me angry. So maybe the most relevant to the dialogue today is, I worry most about the economy. I'm comforted by what is the inherent optimism in the Commonwealth Report, which is it talks about GDP growing again and the economy growing again. And quite frankly, until the economy starts growing again, and that's the history of the world and the history of economics, certainly modern economics, we will not have the resources to care for a growing population and an aging population.
For me, the only thing that keeps me up at night, other than my kids, is did I remember? Did I remember to check that x-ray? Did I remember to call Mrs. Rodriguez? And it's a panoply of small microscopic things that do make up the totality of care. And it reminds me that so much of how our system continues to function is based on the professionalism of individual caregivers. And I think the system knows that by and large, doctors will do the right thing, nurses will do the right thing, so we don't have to fix it. So when a patient needs to be seen, and I'm booked for till 2020, the secretary calls me and says, well, can you see Mrs. Jones? And either and she knows that I'll say sure, have her just come in, and most other parts of the hospital will say no, we close at X o'clock, we can't do that. But the system knows that by and large, the people in the clinical specialties will do it. And so the system never gets fixed for that, and there isn't a way to do that. And although we have electronic medical records and reminders, it doesn't seem to solve the problem that remembering all the things for the patient really falls on the shoulders of the individual caregivers.
What's going to happen to us in the United States in terms of our primacy, I would say, in healthcare around innovation? So I would submit, and I know all the statistics about other countries and the like, that when people are really sick, this is actually the place they come to. It's the United States. They come here for our innovation, for what we've been able to do and how we're able to deliver it. That's what we've got to continue. And if you look at where we are in terms of education, for example, in the sciences, you can no longer argue that the United States is the best place in the world for science education as we're going through. And that's been a change over time. And I think we have to be fundamentally concerned about innovation in healthcare as we make all of these much needed changes. Because I completely agree with all of the premises in the Commonwealth report. We've got to keep that as we're focused on what it means to really be the place that is innovating for healthcare in the future.
I think it's all about the patient experience, completely. And I do believe that an enabler is capitation. I do believe an enabler is a system that's not fragmented, or payers that are not fragmented, can be fragmented even in a capitated system, and one that doesn't demarcate between the hospital, the healthcare provider, and the community. So it's the fragmentation that we need to overcome. So the patient's experience and the families and the communities is at the heart of it. And when you begin to start grappling with how that might change, I think the other things fall out better. Instead of designing great call centers, which we all are working on and trying to make better, I think you begin with what the patient needs to navigate the system, which is very hard to navigate whether you're rich or poor.
I think we got to ask patients what they want, and then we have to actually listen to what they say and then help them navigate through what that means. So when David was talking before about this issue around price transparency, I think it is going to be extremely difficult. I'm for it, but then we have to really say to someone, well, this is what that means. Here, now you need to understand this, and we have to expect that people are smart and care about these kinds of things, and we need to keep at it. We're not doing a good enough job about having that ongoing conversation, and if we ever were doubting that, just think about that conversation about palliative care. We don't do a good job about saying to people all along their lives, what matters to you, right? We're thinking about what matters to us around keeping things going oftentimes when we didn't really listen to what someone's saying. So I think fundamentally the system needs to focus back on the patients and help people with those conversations.